Tonight we have joining us for the evening Jeff Kopp. Jeff is an advanced life support paramedic in both BC and Alberta and is going to be gracing us with terrifying tales of trauma and hemorrhage control tonight. As you guys, I think, all know, these sessions are recorded. They will be posted on YouTube. We try and get them up within a day or two. And those links will get sent out. We haven't released last week's link quite yet. We're just waiting on a confirmation from the presenter before that gets sent out, but it is coming. Yeah, if there are questions, we were talking about this earlier with Jeff, but if there are questions, please just type them into the chat. I'll be curating questions to deliver to Jeff. And if there's something really pertinent that needs to sort of like warrants interrupting his presentation, I'll do that. Otherwise, we'll be trying to save all the questions for the end, you know, have a good Q&A session. Will be an opportunity for everyone to ask more questions as well. Then, so with that, over to you, Jeff.
Well, thank you very much, Nick, and thank you for the introduction. Thank all of you for tuning in this week to listen to my meandering ramblings. Now, I've got a huge amount of respect for St. John Ambulance and the work that they do around the world. So being asked to speak with you tonight is a significant honor and certainly a pleasure. So thank you for having me. Now, to kick this off, why don't we answer the question that some of you may be asking, just who is this guy? So I'm Jeff. I'm a licensed advanced care paramedic in both British Columbia and Alberta. I'm presently practicing with the BC Ambulance Service in Victoria, and I've been involved in EMS for the past 11 years. I've had the privilege of serving 2 provinces and experiencing operations in rural, suburban, urban, and metropolitan areas. I've worked in industry, ground-based EMS, and air ambulance on the fixed and rotary wing aircraft. On top of this, I was a high-fidelity simulation instructor with the primary care and advanced care paramedic programs at St. Polytechnic in Calgary, Alberta. There I was responsible for simulation and hands-on learning with an emphasis on detailed discussions regarding pathology, pathophysiology, and treatment modalities. So, everyone's favorite part, the disclosure. So, I do have a bias towards equipment that I've used in the past, as well as courses that I've taken. I'm going to do my best to go and separate those during the presentation. Throughout the presentation, you'll see various photos which may highlight a particular technique or device. This is by no means an endorsement for that product. There are many different products available and many ways to accomplish your goals. This brings me to my next item. I'm not selling anything. I'm not receiving any financial incentives for this presentation. I have no known conflicts of interest to disclose. And beyond enjoying walks on the beach, I've got nothing else to disclose. So the disclaimer. The biggest thing to take home is that this is not standalone training. It's an avenue to express new ideas, entice questions, and promote personal growth. Hopefully, you'll be able to go forward today asking some questions to your training officers or to your employers with opportunities to expand your treatment regarding hemorrhage management and take better care of those patients in those situations. But as always, please follow your agency's policies and protocols. I understand that there is significant experience within your group being drawn from a number of different fields. But when working under the St. John Ambulance umbrella, please ensure that you're working within the allowed means. And this also means practice within your allowed license and scope. Exceeding that can get you in a whole pile of hot water very quickly. And when in doubt, call a friend. Online medical control, your contact physicians are excellent resources to consult with on difficult cases or to provide orders when required. So without further ado, allow me to introduce tonight's presentation. The terrifying tales of trauma. Now, trauma is an interesting topic and one that most first aid and MFR and pre-hospital training programs focus heavily on. Specifically, that in the emergency management of moderate to major trauma, many of these programs excel in teaching the what and the when to treat, focusing on physical skills and symptoms, but very few dive deep into the why or how. And that's what we hope to explore tonight. So for tonight's topic, we're dealing with hemorrhage management. Let's start off with a definition. Merriam-Webster defines trauma as an injury, such as a wound, to living tissue caused by an extrinsic agent or an agent, force, or mechanism that causes trauma. So with this definition in mind, it becomes rather clear that any injury from a fracture to a contusion, a dislocation to an abrasion, or any laceration, all the way up to an amputation, all fall under that category of trauma. This means that trauma is a very broad subject with many, many topics to cover. And it's also interesting to note that BC EHS reports that up to 60% of all EMS calls they receive are for some form of trauma. Tonight, when talking about hemorrhage management, we're going to be focusing on traumatic causes. Medical causes of hemorrhage are another topic, has deep roots in pathophysiology. And while management strategies for both do have crossover, there's enough diversity that both demand their share of the spotlight. Keeping this in mind, we'll be focusing on the science of hemorrhage control techniques, and treatment goals. There will be time at the end of the presentation for questions, and as Nick has already said, he's monitoring the chat function, so please submit anything that you'd like to know more about. I'll do my best to answer those questions. So welcome to the science of hemorrhage. Let's go ahead and start at the beginning. I'm going to start with the blood. Most people can tell you that blood is red. It carries oxygen. It's rather important. There's a general understanding of blood types, your A, B, and O, as well as your Rh phenotypes. What's actually in blood? Why is it important? And more importantly, what are the components that make up whole blood? It's worth noting that in Canada, very few transfusions, if any, use whole blood. Instead, we break it down into its components in order to extend its shelf life, as well as aid as many patients as possible through targeted transfusion therapy. Now, if we were to take a test tube of blood and separate the components, it would look something like this. About 44% of that sample will be red blood cells. Around 1% is shared between white cells and platelets. And the remaining 55% is the liquid portion of blood, known as plasma. And that's further broken down into water, ions, proteins, nutrients, waste, and dissolved gases. Now, let's start off with the red blood cell. So these little concave discs are responsible for binding to and the transport of oxygen to the body's tissues, as well as the transport of CO2 back to the lungs. And the red appearance is due to the presence of iron. It's found bound to the 4 heme sites on each cell. And that hemoglobin has a natural affinity for oxygen, which aids in its binding process. However, changes in blood pH can affect how tightly the oxygen bonds to those hemoglobin, and in turn can present challenges with in-tissue perfusion. We'll talk more on this very shortly. Now, an important concept to when considering hemorrhage, and specifically significant hemorrhage, is the relative capacity of the blood to transport oxygen. As an example, if we were to compare 2 cylinders, sorry, I had the chat function pop up there. If we were to compare 2 cylinders, one with 100 red blood cells and one with 50, assuming that all of the hemoglobin are bound with oxygen, it would be easy to state that the cylinder with 100 red blood cells would have more capacity and therefore transport more oxygen. What's interesting though is that in both cylinders, the hemoglobin is currently 100% saturated. Where this comes into practice is the use of SpO2 monitors. So these devices use light to register how full the hemoglobin are based are based on the refraction index. They do not read arterial oxygen concentration. So in a normal, healthy person, there is a correlation between SpO2 and PaO2, which makes it a useful tool in engaging hypoxemia. But for severe hemorrhage, patients may, but for severe hemorrhage, the monitor may provide a false high reading indicating that all of the available heme sites are currently occupied. The SpO2 monitor is still a useful tool in a trauma patient, but caution must be used and how much weight is placed into that reading. Also remembering that other factors such as peripheral vasoconstriction can skew numbers. At the end of the day, we want to make sure that we're treating our patient and not our monitor. Because of this potential for a skewed outcome and an unknown degree of oxygen transport and in-tissue perfusion, best practice is to routinely provide oxygen for your major trauma patients. Now, the choice of low or high flow is entirely patient dependent, but a good rule of thumb is to use high flow oxygen via non-rebreather or an adult face mask for your unresponsive patients, or when signs of hypoxia or shortness of breath are present. Onto our white cells. Now, our white cells are the body's first responders. They're often acting as cellular police officers or paramedics, depending on their cell type. Well, white cells play an important role in trauma by cleaning up cellular debris, destroying infectious material, and aiding in the inflammatory process. The role in the acute stage of hemorrhage is relatively limited. Given that tonight's topic is on hemorrhage, we won't be spending too much time, but it is still worthwhile breaking down the various types of white cells. So first up, we have monocytes. They tend to live quite a bit longer than many white cells, and they also have the ability to migrate from the bloodstream into other tissues. There are two subsets of monocytes, macrophages, which engulf and destroy bacteria, and dendritic cells, which present antigens to the cell's surface in order for T cells to later attack and destroy them. The next up is lymphocytes. Now, lymphocytes are differentiated into many different types of cells, such as B cells, T cells, and natural killer cells, and there's further differentiation within those. But lymphocytes are responsible for creating antibodies to fight against pathogens, regulate the immune response, and prevent autoimmunity, as well as hunt down and destroy viruses and other potentially harmful invaders. Neutrophils are our defense against bacteria and fungi, and they're also the most numerous type of white cell, your first line of defense when an infection occurs. Basophils sound the alarm when infectious agents invade your body. Many of you who have allergies are familiar with the effects of basophils. They're responsible for secreting chemicals such as histamine to help modulate the body's immune response. And finally, eosinophils attack and kill parasites and cancer cells. They also help modulate that allergic response that is initiated through IgE-mediated channels and propagated by the basophils. So platelets. Now we're finally starting to get into the different components of clotting and where it all starts. So platelets are the first line of defense against hemorrhage. So these cell fragments, which are produced in the bone marrow, they float through the plasma in an inactive state. Once they're exposed to hormones like tissue factor, which is released from damaged epithelial cells, or exposed collagen, the platelets will go and grow little arms. And these arms are very sticky. They'll start to glom together and create a floating raft. As they approach damaged tissue, they'll attach to the side of it and begin to raft together and create a unstable clot. Now, this initial clot is not very strong, but it is capable of slowing hemorrhage while awaiting the activation of fibrinogen and the formation of a fibrin cross-linked bond. But what about plasma? Plasma is 90% water, which leaves the remaining 10% to carry out all of the work. Not a very fair division, but it's how it happens. So what are the things that plasma does? Well, plasma is involved in the regulation of pH. It does this by binding excess hydrogen ions to large proteins, and in doing so, the plasma is able to reduce the number of free ions and maintain a slightly alkaline environment within the blood. Normal blood pH is 7.35 to 7.45. Plasma also plays a large role in temperature regulation. An easy comparison would be regarding the fluid in your car radiator. Circulating fluid is able to pick up excess heat from one area and deliver it to other areas of need. Now, with significant fluid or hemorrhage loss, this process becomes impaired. We'll speak more about it very shortly. Plasma also houses your antibodies or immunoglobulins. They're the tripwire of the immune system. They bind to invading pathogens, marking them for the white cells to come and attack and destroy, and in some cases, neutralizing them on contact. Albumin are the largest proteins within the blood, and they're important because they maintain colloid osmotic pressure. Now, because they're so large, they do tend to stay put in the bloodstream, which is good because their pull plays a large role in the balance of water within the blood and extracellular tissues. So albumin is also a common binding site for the transport of medication. Because it's a fast path around the body, plasma also takes the role of delivery for electrolytes, nutrients, hormones, and chemical messengers. And dissolved gases such as oxygen and CO2 are in the plasma, however, relatively low concentrations as the majority is being bound to the red cells. There is a degree of nitrogen that's found in the plasma as well, but processes within the body tend not to use nitrogen. Now, the last two items, fibrinogen and clotting factors, are the most relevant when discussing hemorrhage. In fact, it's a topic so important, they need their own section. I do want to point to the one slide there with the fibrin clot. And it's interesting to note the mesh-like framework that's formed in order to maintain the platelet plug, as well as binding other agents and capturing them in order to form that stable clot. So on to clotting factors. Now, the process of clotting, and specifically the coagulation cascade, is a very complicated topic. This diagram, no doubt, has been the subject of many medical students' nightmares. Fortunately, we can somewhat simplify the process. The coagulation cascade is divided into three categories. You've got your intrinsic pathway on the left, which is initiated by collagen exposure or other internal factors. You have the extrinsic pathway on the right, which is initiated by vessel damage, such as trauma. And you have the common pathway, which is a big blue box right in the middle, which is shared by both. Now, today we're going to focus on the extrinsic pathway, which is shown in yellow. Now, the important thing to understand with the extrinsic pathway is that vessel damage must occur, which in turn will release tissue factor. Now, once released, the cascade can begin. Tissue factor is also one of the catalysts that initiates platelet aggregation, as described earlier. But the specific chemical changes that occur during the cascade are not important for this lecture. But I do want to draw your attention to the common pathway for a moment. Just as we learned, or as we just learned, fibrinogen is present within the plasma. Through the cascade, clotting factors will activate fibrinogen, turning it into fibrin. And this mesh in turn solidifies the platelet plug, resulting in a stable clot. Now, there is another component to this, and that is after injured tissues have been repaired by the body, we need to remove whatever clots were formed. And it does this through a process called fibrinolysis. So it is fortunate that we have this process in place because your body is constantly creating and dissolving clots. Without an ability to break them down, you would quickly become a walking clot and your blood wouldn't move very well. Now, like the conversion of fibrinogen to fibrin, fibrinolysis occurs when inactive plasminogen is converted into its active form plasmin after being exposed to its catalyst, which in this case is tissue plasminogen activator, TPA for short. Now, TPA may sound familiar to some of you, especially if you watched the previous talk on stroke. TPA is used as a medication in the treatment of CVA patients as well as MI patients by harnessing the body's own mechanisms to go and initiate the breakdown of clots and open up those clogged arteries once again. But if we can force the clot breakdown, what about preventing it from happening? That's where TXA comes in. TXA, or tranexamic acid, works by blocking the breakdown of fibrin bonds. We'll talk more on this later, but currently you can generalize by saying that TXA is the anti-TPA. So what about other medications? What other drugs will affect the coagulation cascade, effectively thinning the blood and extending clotting times? Well, perhaps the most common of all is warfarin. Now, warfarin has effects on many parts of the cascade, and this is one of the things that makes it very effective at modulating coagulation response. And while warfarin has a relatively narrow therapeutic window requiring regular blood testing, its effects are also reversible. More recently, novel anticoagulants have started taking over, most of which focus their effects on factor 10. These are medications that you may have seen, such as rivaroxaban, apixaban, and enoxaban. Now, factor 10 sits right at the top of that coagulation cascade, so it's taking both factors from the extrinsic and intrinsic pathway, which make it effective at its job. They do require less frequent blood testing because they've got a wider therapeutic window, but until very recently, there was no way to easily reverse them, which led to increased risks of hemorrhage and difficulty with management. And the only other item of note and commonly seen medication that I want to mention is platelet inhibitors. Now, while not technically an anticoagulant and not having a direct effect on the coagulation cascade, medications like ASA, clopidogrel, and ticagrelor, though working through different mechanisms, still have an effect of slowing the production of, or preventing platelet aggregation, and in turn, slowing that formation of a clot, which has the same net effect on hemorrhage times, or serum clotting times. Now, a different way that we can look at the coagulation cascade is this. On the far left, we'll see that vessel injury occurs, and those epithelial cells will release the chemical messenger tissue factor, which in turn will start the coagulation cascade, but also stimulate the amalgamation and aggregation of platelets. Once those platelets start to glom together, they'll form an unstable clot and a platelet plug, and once in place, the fibrin is able to join the party and create a strong cross-linked fibrin bond. At that point, it moves from a soluble state to an insoluble state, and the risk of continued hemorrhage from that clot is reduced. Now, while we're on the topic of the science of hemorrhage, we're going to go down the route of the aptly named trauma triad of death. That's a big, scary title, and the reality is that it's something that a lot of you may have been exposed to previously. So the trauma triad of death, some of you may have seen this before, and it's comprised of 3 interconnected components. Now, these components all feed into one another, and if uncorrected, the triad will continue to propagate until complete exsanguination occurs. So it's our job as first responders to go and understand this triad, and more importantly, intervene in it early to prevent certain death. Now, we can further expand on the triad by looking at it in this form. Starting with the initial injury, hemorrhage begins. As blood loss worsens, coagulopathy develops. The biggest thing to note with this is that note the bidirectional arrows below hemorrhage and above coagulopathy. As hemorrhage worsens, coagulopathy worsens, and coagulopathy will continue to propagate as the triad, and in turn will make the hemorrhage continue and worsen. On the left, we have exposure, and exposure can be to the elements, it can be to wetness, it can be to the removal of clothing, or significant inactivity. And all of these components can constitute as exposure, but the net result is setting the patient up for exposure hypothermia. Once we move into hypothermia, again, it feeds into that triad and will continue to propagate. We'll break it down a little bit further in a moment. Now, on the right, we have hypoperfusion. Now, hypoperfusion can be due to many factors, but in traumatic hemorrhage, hemorrhagic anemia is certainly one of the top contenders. As we lose that volume of blood, and more importantly, that contents of red cells, our relative ability to carry oxygen is decreased. Vasoconstriction also plays a role by reducing the flow of blood to those tissues. Impaired cardiac function, both due to acidosis as well as reduced filling pressures and loss of Frank-Starling's mechanism, all result in the production of more metabolic byproducts and in turn worsen the acidosis. So let's look closer at these various components of the triad. Starting, of course, with coagulopathy. So coagulopathy is the inability for the blood to form a clot. And this can be due to depletion of platelets or clotting factors secondary to hemorrhage, the alteration of the clotting cascade by medication or disease factors, relative dilutional coagulopathy secondary to overly aggressive fluid resuscitation, or severe and uncorrected acidosis resulting in the deactivation of proteins and enzymes. Now, the biggest thing to remember and correct is that the triad starts and begins with bleeding. So the first goal is to find the bleed and aggressively stop it. Also, don't stop searching at the first source that you find. A detailed trauma assessment still needs to be completed. A smart man once said, always look under the shirt, but also always look under the collar. You never know where a bleed may be hiding, and unless you personally have examined that patient, it's difficult to make sure that you've gotten all of those bleeds. Next up is limit your fluid resuscitation. So not only can crystalloids worsen acidosis, but they can also cause a dilutional coagulopathy. If we spread the coagulation factors out too far, they're no longer in a concentrated form in order to have their intended effect, and your clotting times are going to extend. IV fluids and fluid resuscitation may improve a number, but ultimately they're going to hurt your patient if done without thought. Now, a patient with significant hemorrhage ultimately needs transfusion. To date, medical science hasn't developed an appropriate replacement for oxygen, the oxygen carrying capacity of red blood cells, nor the coagulation properties of plasma or platelets. So for significant hemorrhage, blood is still the go-to replacement. Now, what about tranexamic acid? If we can get it on board early in internal or uncontrolled hemorrhage, we can slow the breakdown of those newly formed clots and promote the stable clot to form into an insoluble state. Now, the goal for these patients is to provide it early, ideally within an hour, but up to 3 hours after the initial injury. And the impressive thing is that if delivered within an hour, it's been proven to have up to a 5% in overall improvement and reduction in mortality. It's a significant change. And within the first 3 hours, it's still a 2 to 3% improvement in overall mortality. With all adjunct therapies, it needs to be considered after initial management of that hemorrhage have occurred and transport has at least been initiated. Be highly suspicious of any patients with a pre-existing coagulopathy, such as hemophiliacs or those on anticoagulants. Any changes in that coagulation cascade can make these patients significantly harder to manage and require aggressive therapy in order to get them under control. So acidosis. Now, the body's natural blood pH normally sits between 7.35 and 7.45, with acids on the pH scale sitting left of 7. Now, when the body moves outside of this range, the ability for oxygen to bind to the hemoglobin becomes affected. Catecholamines can become ineffective, and even proteins and enzymes within the coagulation cascade can deactivate. Generally, with a pH less than 7.1, we start to get very concerned surrounding our ability to appropriately resuscitate these patients. Now, there's many causes for pH shifts in different disease states, but for trauma, the one we're most concerned about is lactic acid. The question is, what is lactic acid? And the answer is it's a metabolic byproduct which is produced by the cells when they switch from aerobic respiration to anaerobic respiration. This is just a fancy way of saying with or without oxygen. But normally in aerobic respiration, the cells produce around 30 to 38 ATP, or adenosine triphosphate, per cycle, which they use as an energy source. And in doing so, because it's such an efficient reaction, they produce very little waste. Now, when they switch back to anaerobic, or when they switch to anaerobic respiration due to poor tissue perfusion, they produce only 2 ATP per cycle. The end result is that in order to maintain cellular homeostasis, they need to work significantly harder, and in turn, they're producing more waste. So why does this change from aerobic to anaerobic respiration occur? And the answer lies in overall decreased perfusion. So as discussed earlier, anemia from significant hemorrhage will affect the oxygen carrying capacity of red cells. Vasoconstriction secondary to hypothermia and blood loss will reduce the flow to tissues, and overall decreased cardiac output will reduce the outward flow of blood, and all impacting oxygen delivery. So to work against this, we need to maintain a patent airway and effective ventilation. So going back to basics, your ABCs. We also need to strongly consider providing oxygen routinely to our major trauma patients. We want to ensure that the available hemoglobin are as saturated and full of oxygen as possible, and if possible, and also hypersaturate the plasma to ensure maximal tissue delivery. We also want to correct any pneumothorax that is present because it can cause challenges such as obstructive shock or impaired ventilation. Both are going to worsen tissue perfusion. Please limit your saline delivery. On average, normal saline has a pH of around 5.5, making it significantly more acidic than the blood, and in turn worsening acidosis. Now, other crystalloid fluids, such as lactated ringers or plasma-lite, have a pH of 6.5 and 7.4 respectively. But the end result is that all of these will start to play into the worsening cascade, which we'll talk about shortly. Regarding your fluid replacement, we're going to target end organ perfusion as opposed to a number. And we're going to adopt a permissive hypotensive strategy when traumatic brain injury is not a concern. We'll talk more about that at the end of the presentation. Also, limiting fluid replacement will reduce the risk of dilutional coagulopathy as well as anemia. And number 6, correct the other two. Acidosis is one of the more difficult components of the triad to go and correct. And by fixing the other 2 components, we can have a more significant effect on that patient's outcome. So moving on to hypothermia. Hypothermia is often one of the most overlooked components of the triad, but it's also one of the easiest to correct. Now, this may be due to a misconception that the ambient temperature needs to be low in order to get cold. Post-action reports from the US and Canadian militaries have shown that that soldiers injured in battle, even if they're in the middle of a desert, are routinely developing hypothermia post-injury. In fact, in a 2004 study on hypothermia in the traumatic patient, they found that a core temperature of less than 32 degrees Celsius was associated with a 100% mortality, independent of the presence of shock, severity of injury, or the degree of fluid resuscitation. Again, we go back to that loss of circulating plasma and its effects on temperature regulation. As we start to lose the fluid, the ability to move heat from the core areas out to the periphery is lost. In burns, we end up losing the benefits of the integumentary system, maintaining that homeostasis. And at the end of the day, it comes back to how can we fix it? Well, first, assume that your patient's temperature is low to start with and is going to be falling. So if we chronically work to reduce exposure and retain as much heat as possible, especially during prolonged extrications, we're already putting ourselves ahead of the curve. So remove wet clothing, try and get them out of the elements as quickly as possible, and utilize blankets judiciously. Second is turn up the temperature. Preheat your ambulance or your clinical space. And a good take home is if you're comfortable and not sweating, the patient is in trouble and they're not comfortable. The other component, chemical blankets or packs can be an excellent tool to assist in keeping the patient warm. Don't forget the basics. Blankets are your friend, and also, if we manage the hypothermic patient well, treating the hypothermia will have the added benefit of reducing the metabolic byproducts caused by shivering, and in turn prevent the worsening acidosis. Avoid or limit your administration of room temperature IV fluids. Room temperature fluids are typically between 15 and 20 degrees Celsius. They're significantly lower than the ideal body temperature of 37 degrees. So either limit your administration or use an IV warmer, targeting for around 40 degrees. So on to hemorrhage, use IV and blended fluid warmers. So on to hemorrhage control. Now, uncontrolled hemorrhage continues to be one of the leading causes of preventable death around the world. The shocking thing is that simple measures to limit or control ongoing hemorrhage can have a significant impact on survival. Now, it's important to remember that a hemorrhage does not have to be large to be lethal. Many small hemorrhages will add up and can equate to significant blood loss. The root of all techniques is based in slowing or stopping the flow of hemorrhage, allowing the body time to form a stable clot. So the biggest question is, what can we do? And the answer is quite a lot. From direct pressure to wound packing, the use of tourniquets, pelvic binding, and ultimately surgical intervention, preferably within the golden hour, are all things that we can do to improve our patient's outcome and manage those hemorrhages effectively and quickly. So let's start off with direct pressure. So it's a skill that's taught in nearly every first aid program around the world, as well as an instinctual action when injured. And the skills of putting white on red is an invaluable tool for hemorrhage control, but how can we do better? Now, when done correctly, direct pressure is one of the most effective means for controlling hemorrhage in minor to moderate bleeds. However, to be effective, the pressure needs to be applied directly to the bleeding site. So before applying dressings, you need to first identify the location of hemorrhage and focus your pressure in that area. Using firm, steady pressure with both hands if possible should staunch most bleeding. But if your efforts are still ineffective or the hemorrhage is not controlled, reconfirm your site selection and ensure adequate pressure before escalating your hemorrhage management. Now, alternatively, you can also move to focused digital pressure, using your fingers to press on that wound tract and those hemorrhage sites, which may be more effective by concentrating the force in a much smaller area. Now, as with all things medical, there is a caveat. Should the hemorrhage be catastrophic, or if you're on your own and short of hands, moving quickly to more aggressive means may be required. It's best to think of hemorrhage management as a continuum. It's one where you can start or end wherever a patient's condition or other factors dictate. So the next item that's effective for managing hemorrhage is wound packing. I've been told by your training officers that currently wound packing is not under the allowed therapies for St. John Ambulance. But given its effectiveness and the ability to control hemorrhage in areas of underserved by tourniquets, it demands mention. Now, please do not attempt wound packing unless you've completed a training program and or are allowed to do so under your employer. Wound packing is ideal to control hemorrhage in areas where a tourniquet cannot reach, namely the axilla or inguinal folds, so the armpits or the groin crease. And it should be mentioned that wound packing is not used for injuries on the torso, the head, or the neck. The reason being is that we'll lose a lot of gauze into the torso region, and injuries to the head and neck tend to do well with direct pressure or pressure point application in managing those hemorrhage. Now, wound packing, like direct pressure, require that you first identify the source of the hemorrhage. This may be challenging in some deep wounds, but once identified, you'll be able to apply direct pressure to the hemorrhage site. As with external direct pressure, keep maintaining pressure on that dressing once the bleeding has been stopped needs to be maintained until arrival at definitive care. So what about tourniquets? Tourniquets are a wonderfully simple but extremely effective means at stopping significant extremity hemorrhage. They can be improvised with a triangular bandage or commercially prepared device, but the end goal is the same. We're looking to cause arterial compression and cut off the blood flow to the injured limb. Now, older teachings stress that the tourniquet was a last-ditch effort, one that you applied only when you needed to, and you're required to loosen it every 15 to 20 minutes in order to promote circulation to the limb, or it would be amputated. Thanks to data coming up from military conflicts, this information has been updated. And tourniquets have been shown to decrease the time to hemorrhage control by limiting overall blood loss. And it has also been shown that the tourniquets are able to stay in place for up to 2 hours on a limb without any significant impairment to that limb. So the current teaching is now promoting early application of tourniquets in any significant extremity hemorrhage. And once applied, leave it alone. The tourniquet should remain in place until the source of the hemorrhage can be controlled by some other means or arrival at definitive care. So how do you best apply a commercially prepared tourniquet? Well, first, select your site. Placing the tourniquet approximately 2 inches proximal to the injury site, so close to it, and being sure to avoid placement over a joint, such as an ankle, knee, wrist, or elbow, is your first step. Now, once you go and apply the tourniquet and you've selected your site, make sure that you take all of the slack out of the tourniquet before engaging the windlass. If you can slip more than 2 fingers under the band of your tourniquet, you probably have too much slack. Ensure that the band is tightly secured to prevent accidental loosening, and tighten the windlass until the bleeding stops. Now, it is important to note that incomplete amputations, they may continue to bleed even though you have appropriate compression with the tourniquet, and that bleeding will occur through the marrow channels. You won't be able to compress these vessels, so adding different adjuncts may be required. Now, after the application of your first tourniquet, if hemorrhage control is not effective, you can certainly add additional tourniquets immediately next to or above the first one. The increased compression should slow or staunch that bleeding fairly quickly. Now, what about external closures? The oldest and most effective form of wound closure by far is the suture. Well, the challenge with sutures is that A, you need to be licensed to do them, and B, you should probably be practiced in the skill. Now, the goal of all external closure, forgive me, my slides aren't working. So the goal of all external closure is to draw the wound edges together, reduce the exposed surface area, and promote tissue regeneration. So another option for minor to moderate lacerations, which you're probably familiar with, is to use adhesive wound closures or hybrid devices. Much like a suture, they're able to grab onto either side of the wound track, pull it closer, and promote healing. But in severe traumatic hemorrhage, they're not able to keep up. Now, there is a newcomer to the external hemorrhage game, and that is the IT clamp. Now, the IT clamp looks kind of like a hair clip. And what makes this device unique is its usability to control major hemorrhage in difficult to treat areas, such as injuries to the scalp, the neck, and other junctional areas. How it does it is by pulling the wound edges together and creating a very tight seal. As the wound continues to bleed within the sealed area, pressure builds and mechanical pressure is placed onto that hemorrhage site. Eventually a clot will form and your bleeding will be corrected. How about hemostatics? Everybody likes to talk about hemostatics because they're new and sexy and they have a lot of lore behind them. And they've improved greatly since they first came out. And no longer do they produce significant exothermic reactions, and the variety has also expanded, as well as costs have come down drastically. The biggest take home with hemostatics, though, is that they can't be looked at as a replacement for appropriate and aggressive hemorrhage control techniques, but instead uses an adjunct to speed clot formation and improve clotting times. Now, present-day hemostatic agents fall into one of three categories, 4 if you count the mechanical device. First up is Traumadex. Now, Traumadex is a factor concentrator. It uses potato starch, and in turn it removes water from the blood, pushing all of the clotting agents closer together and hoping to speed the formation of the clot. The studies have shown that it is less effective than some of the other techniques, and as such, presently there's no major military operations that are using this type of hemostatic agent. Next up are your mucoadhesives. Mucoadhesive agents are a really unique product, and they're available for a number of different manufacturers. Personally, I have experience with the Celox product and have found good efficacy with it. But these products work through something called Pitocin, which is broken and ground up shrimp shells that have been heavily processed. Now, when it comes into contact with blood, this shellfish protein swells and aggregates, very similar to a platelet. Then forms a plug and will slow the rate of hemorrhage. Now, it is good to know that with this style of hemostatic pressure dressing, pressure must be maintained on the plug to keep it in place. But once in hospital, the gel is easily cleaned from the wound for surgical closure. Being a shellfish product, there is always going to be concern about using this in somebody with a significant allergy, but the FDA has done their own research and found that due to the heavy processing of the Pitocin, the risk of an allergic reaction is extremely low. So the final hemostatic agent within the group is your procoagulants. Now, this, the most notable being the Quick Clot brand. These products use kaolinite, which is an aluminum silicate, and its job is to go and start the cascade and expedite it. So Quick Clot has direct effects on the clotting cascade, specifically factor 12, and will initiate that clot formation. You do still need to have clotting factors present though, so in significant coagulopathy, Quick Clot may lose its effectiveness. The final addition to the list is marketed as a hemostatic agent, but really does so through more of a mechanical means and has more in common with wound packing. Now, this product is called the X-Stat, and it's an injector-style device which forces these tightly packed sponges deep into the wound, and once saturated, they quickly swell, filling the cavity, thus applying mechanical pressure on the hemorrhage site and stopping the bleed. Next big thing to talk about is pelvic binding. So in pelvic binding, the big take home is that the pelvis is very strong. If you manage to break it, there's likely a lot of force expended. Further to this, there's also some very big blood vessels that run through there. So any damage, any of those vessels can be catastrophic. The challenge with pelvic hemorrhage is space. There's a lot of room in there. In fact, you can lose up to 4 to 6 liters of blood into the pelvic space before effective tapenade occurs. So traditionally, pelvic binding was only done if you were highly suspicious that a pelvic fracture had occurred, and normally after an overly aggressive pelvic rock and squeeze test. Current literature is now supporting the more routine application of pelvic binders for major trauma patients, and the increase in commercial products is making it easier than ever to apply on scene with even or equal force distribution. So why? Why should we bind more patients? What's the benefit? And does it actually make a difference? And the long and the short of it is yes, it makes a huge difference. By binding the pelvis, we decrease the likelihood of re-injury during transport. We also decrease the overall volume of the pelvis, making tapenade more likely and the control of a significant internal hemorrhage possible. Providing pressure on those pelvic bones, we're also compressing the vasculature around the pelvis and slowing the bleed if there's one that is compressible from an external source. Further to it, stabilizing that pelvis is going to decrease pain. Just as in fracture management, if we decrease the patient's pain, their overall metabolic requirements are going to decrease. Thusly, we're going to produce less metabolic waste, and we're not going to worsen acidosis as quickly. So how do we do it? Well, manual stabilization is a good go-to. A couple of hands either side of the pelvis is an excellent place to start, or using available means such as pants or belts. The sheet and triangular method, which I've been told has been taught within the St. John umbrella, is still a very viable technique. All we're looking to do with that method is prevent further splaying of the pelvic girdle. The ability to apply significant force is going to be limited, but any reduction in stabilization of the pelvis is going to help the patient. And finally, we have our commercial products. Products like the T-Pod are extremely easy to landmark, apply, and provide compression to the pelvis. So what about fractures? Now, I'm not going to spend a lot of time on fracture management. This is a topic that is best taught in person and is likely one that you focused a lot of your training on previously. But essentially, we're most interested in stabilizing long bone fractures and reducing the likelihood of a broken bone causing further tissue or vascular injury. At the end of the day, if it's broken, splint it. The biggest take home that I've been asked to emphasize by your training officer is when should you load and go versus stay and stabilize? And quite honestly, it's a gray area question. Patient's condition, your time to the hospital, and your means and route of transport all need to be considered. If you're going to be driving for an hour and a half down a dirt logging road, all of a sudden fracture management becomes a significantly more problematic challenge. But a good idea is to focus on large hemorrhages and earlier long bone fractures. Manage your C-spine per your local protocols, and then get moving. Once transporting, though, don't forget to go back. Reassess all of your interventions done on scene and splint any fractures that weren't managed. If we can go and reduce that patient's pain, again, it plays into a more comfortable experience, but more importantly, a reduction in the metabolic demands. So what about amputations? So first and foremost, control the hemorrhage. Second, always treat an amputated part as if it could be reimplanted. At the very least, it may be useful for using the skin in order to cover a portion of the wound or the stump. Now, for an incomplete amputation, treat it as a fracture. Stabilize the limb with a splint and clean the wound with saline irrigation only. But for a complete amputation, first of all, find all the big pieces. Handle the amputated part with care. Don't debride it. Irrigate with normal saline and pack loosely with sterile saline soaked gauze. Place that whole package into a watertight plastic bag and store in an ice bath slurry. If that's not available, opting for moist dressings and placing chemical cold packs around them may work in the interim. With both techniques, make sure that the ice does not directly contact the amputated part. Reimplantation is less likely to be successful if warm ischemia time exceeds 6 hours in general, but success has been achieved for 2 to 24 hours. So effective and appropriate management of these patients should always be a goal, and reducing the amount of time on scene is one of the hallmarks. So what about IVs? IV therapy is highly talked about subject, and there's many opinions, but by and large, there's been an adoption of limiting fluid resuscitation in trauma patients. This is for many reasons, but the most common is that normal saline isn't very normal, at least not in terms of the human body. First off, normal saline is extremely acidic relative to the body, and that worsens your acidosis. It's normally served cold, room temperature of 15 to 20 degrees, which is quite a bit lower than the body's 37. And that's going to affect your hypothermia. It's frequently over-administered, resulting in dilutional coagulopathy, worsening anemia, as well as relative hypovolemia, secondary cyclic administration, and over-resuscitation of IV fluids. Also doesn't carry oxygen. Now there are some synthetic blood products that are out, and they've had moderate success, but by and large they're not available, and or they come with a significant risk and cost down the way. It also leaves the intravascular space very quickly. Because it's just a water or a water product, it's able to go across the epithelial boundaries and into the intravascular space easily. So what about other options? Well, lactated ringers has a better profile, but hasn't been widely studied and may not be compatible with medications. Plasma-Lyte has by far the best pH and is the closest balance to blood chemistry, but it's cost prohibitive and not widely available. Things like colloids haven't really been shown to improve mortality. And again, availability and training are a challenge. So really, there's no real good replacement for blood. So why do we even bother at all? Why are we going to start an IV on these patients? The answer is it can be used sparingly. We can use it for volume resuscitation, so long as we're doing it in a thoughtful and controlled manner. We can provide access for blood transfusion at the hospital. And it can also be used for medication administration, for pain control. And more importantly, we use it for TXA. So TXA, or tranexamic acid, is counted as the wonder drug. Now, if we look back at the coagulation cascade, you'll notice that in the middle of the fibrinolysis pathway, TXA takes its place before clot breakdown can occur. Now, to understand why this anti-TPA function is important, it helps to see how TXA works. If we look at the diagram on the left, you'll see that the normal action of TPA activating plasminogen, which converts into plasmin and then attaches to the fibrin degradation receptors. Once that occurs, the degradation products are released, the bonds are broken, and the clot is dissolved. But on the right, we can see that there's a small block, which is now blocking the plasminogen receptor, even before it's activated and turned into plasmin. With that block in place, the plasmid is not able to bind to the fibrin. Now, the important thing to note here is that TXA does not impact the activation of plasminogen in the plasmin, but it rather prevents it from binding to the fibrin clot. The net result is a reduction in the degradation of newly formed clots and a higher likelihood of the clot reaching an insoluble state where it is now a stable clot formation. So let's talk about treatment goals. When it comes to hemorrhage management, our primary goal is to get the patient to definitive care as quickly as possible without exacerbating their injuries. How we do this is dependent on the tools available to you, the training that you've received, and your past experience. We can boil the principles of hemorrhage management down to 3 things: stop the bleeding, perfuse the tissues, and keep them warm. We've already covered these items in depth in previous sections, but number 2 could still use some expansion, specifically regarding blood pressures. One of the more common things practitioners can fixate on is the blood pressure, specifically systolic pressure. And this idea of the systolic pressure being targeted for 90 has been passed through trauma programs for many years. Now, this theoretical, the theoretical reason is that going higher than 90 could pop clots, and going lower than 90 isn't good for the patient. But training programs and agencies don't normally explain why or how this number has come to be decided on. And further to it, they continue to use these set numbers in an effort to reduce your cognitive loading and provide identifiable targets. There's, of course, more to the picture. So I'd like to introduce the mean arterial pressure. So the mean arterial pressure is a calculated number, which is diastolic times 2 plus your systolic divided by 3. And it starts to paint a bit of a different picture of tissue perfusion. Now, this map is a window into the average arterial pressure during a full cardiac cycle, and in turn, it's been used as a surrogate for tissue perfusion. Now, through studies, it's been identified that the average person, a map of around 65 is required to perfuse the kidneys. Lower than that is ineffective, and higher than that is overzealous. Now, what's further interesting is that all of the above blood pressures here all calculate out to provide a map with a minimum of 65, even though some of them have a systolic less than 90. So what's right? The challenge is that, like a systolic blood pressure, this is just another number. Good context doesn't provide a full picture. So how can we change things? What are our end goals? The end goal, of course, is end organ perfusion. So what are our end organs? We've got our brain, our heart, our lungs, our kidney, liver, and skin. But out of those, the easiest to identify in the pre-hospital world are the brain, heart, lungs, and skin. So how can we assess these organs? We can look at overall tissue perfusion. As far as CNS, when well perfused, you'll have no effects on cognition. As perfusion starts to decrease, restlessness, becoming apathetic towards the situation, or severe anxiety may start to present. And as perfusion further drops, agitation, confusion, and eventually coma are all signs that the brain is being underperfused. Now, the brain is also taking the majority of your glucose and oxygen stores. So it's one of the first to show signs of perfusion, and is an excellent indicator of overall systemic perfusion. How about your heart? Well, as you bleed, your heart rate's going to increase in order to maintain appropriate stroke volume and tissue perfusion. As perfusion further decreases, you're going to see more increases in the heart rate. That second increase is normally a fairly bad omen, because as we reach the third increase, we're right on the precipice, and they can quickly round the hump where they're no longer perfusing their heart muscle, and bradycardia results. Once we move into the bradycardic stage, we're well on our way to cardiac death. As far as respiratory, again, in a well-perfused or a minor reduction in perfusion, we're going to see no change in that respiratory system. But as perfusion starts to decrease, the ventilation is going to increase. And this is due to two causes. One, the body is trying to increase its overall tidal volume of minute ventilation in order to increase oxygenation and saturation of blood tissues to provide oxygen to the cells. But that minute ventilation is being increased when we blow off the additional byproducts. The acidosis and lactic acid that's being produced due to low perfusion is increasing or is being blown off as CO2. So if we're seeing our patients starting to become more and more tachypnic, it's a bad sign. It means that we need to work hard to start to change some of those items within the triad. But by and large, the skin is a window into overall perfusion status. And it would be my argument that looking at the skin and CNS alone should be able to guide your resuscitation. In the skin, it's going to show very early on delayed capillary refill. And as vasoconstriction progresses and perfusion drops, you're going to start to develop cold, flabby extremities. Perfusion will further drop, resulting in mottled or cyanotic appearance. And that's, the body is at that point shunting as much blood to the core in order to perfuse the core organs. Using these as treatment indicators is an excellent way to start directing the therapy. So I would like to introduce the idea of permissive hypotension and also volume-restricted resuscitation. So permissive hypotension is an approach of allowing a patient's systolic blood pressure to fall low enough to avoid further hemorrhage, but high enough to maintain perfusion, thereby reducing the likelihood of disturbing an unstable clot, as well as reducing over-resuscitation, which can help to lead to further coagulopathy. Now, it should be noted, there's no set blood pressure goal, but rather an expectation based on physical findings, and the most reliable being mentation, that in the presence of additional complicating factors, such as intoxication, traumatic brain injury, or altered mental state, you should be able to use those as a goalpost to target resuscitation. The BCEHS has adopted a hybrid of these two systems, and in turn, their guidance to paramedics is to target resuscitation for perfusion and mentation, focusing on skin signs and CNS signs, but also a systolic blood pressure target, a set of 70 to 90 in non-head injury patients. Now that is the biggest caveat that I have to put out regarding permissive hypotension, is that if a TBI is suspected, please do not manage your patient with permissive hypotension. In cases where competing interests are present, current literature is recommending that you treat the traumatic brain injury and aim for a higher mean arterial and systolic target to reduce the likelihood of hypoperfusion to an already struggling brain. Retrospective data suggests that systolic blood pressures of less than 90 doubles the risk of mortality when involved with a TBI. BCEHS is also currently recommending a systolic blood pressure target of at least 120 millimeters of mercury in those patients, in that subset of patients, and also looking for other factors such as head of bed to 30 degrees in order to promote venous drainage. So I'd like to wrap up tonight with some top 10 trauma principles, and this has been provided courtesy of the BCEHS. And these are all good standalone points, but once again, please practice within your scope. The biggest item regarding trauma management is to minimize your scene time. Keep it 5 to 10 minutes max. And if you're working as a team, make it clear to everyone that that is your treatment goal. If you identify that you need to be off scene within 5 minutes, you can be guaranteed that your team is going to work hard to make that happen. Any or all non-ABC interventions, with the exception of significant hemorrhage management, can be done en route. Keep the patient warm. Again, working to fight against that triad of death, we're looking to mitigate hypothermia. Don't cut the clothes off until you're inside of a unit or a clinic, if possible. Cover the patient with a blanket. Use warm IV fluids if possible. A spinal motion restriction, again, follow your local protocols, but in major trauma, spinal motion restriction becomes just that, a reduced function of the traditional spinal motion mobilization in an effort to get the patient moving quickly. So avoid gross neck movement, and more important, it's more important in blunt trauma and less important in your isolating penetrating traumas. Don't go after your spinal motion restriction at the expense of your scene time. Now, near routine pelvic restriction is also indicated, and we're using a basis of pain or mechanism as the primary goal. So when in doubt, bind the pelvis. Control all of your bleeding, and remember that small bleeds add up. Be aggressive with your management. Use any or all techniques that are required in order to appropriately rein in that hemorrhage and move forward. Routine oxygen administration is ideal because we're going to go and saturate the plasma as well as the available hemoglobin and decrease reduced tissue perfusion. Warm your IV fluids if possible. Try and get 2 large bore IVs in preparation for a large volume trauma resuscitation at your receiving center, and target 70 or 90 for non-head injury patients or 120 in patients with head injury. Now, for head injury is a whole other discussion and other talk, but the biggest take home for head injury patients is to increase your systolic or mean arterial goals, avoid hypoxemia, ensure hyperoxygenation of those patients, ensure appropriate ventilation, but don't overventilate. Keep any restrictive collars, ties, or other equipment from the neck in order to not impair venous drainage, and incline the head of the bed up to 30 degrees. In general, the human body works better in the elevated state. By doing so, we're going to displace organs from the diaphragm, improve the ability for ventilation, we're going to improve venous drainage. So as a go-to, unless there's a contraindication for it, increasing or inclining the head of your stretcher 15 to 30 degrees is an excellent thing to do with patients. A TXA infusion, again, using signs of shock hypoperfusion or uncontrolled bleeding, and we're targeting for administration in less than 3 hours. Over 3 hours is no longer indicated, and that is, they found that it can be detrimental, either leading to significant hypotension or the breakdown of clots. We're no longer trying to prevent the breakdown of a new clot, and at that point, the risk of new clots forming elsewhere leading to occlusive stroke, pulmonary embolus, or MI also increase. Follow your protocols for your administration of TXA and your guidance by the right direction. Now with management, BCHS follows AIM, but follow whatever policy or procedure your training agency is using. Maximize your non-invasive area management and focus on basic techniques. Look to 2-person BVM to improve seals and high-flow nasal cannulas in order to increase your oxygen delivery, especially in a pre-intubation setting. So with that, I've got some resources that are available for you, and apparently a colorful deal I don't know how to get rid of. The resources in front of you are they're sort of tip of the iceberg. Stop the Bleed is a international force that is focused on the hemorrhage and science, the science of hemorrhage and how we can best reduce it. Canadian Blood Services has excellent information on blood products. Trauma Services BC is our go-to for in-province resources, and of course BC EHS treatment guidelines. So with that, we'll open it up to questions, and I'll see what I can do to answer whatever we have.
Thank you, Jeff. That was a fantastic and very, very in-depth talk. We've got a whole whack. That's a metric unit. A whole whack of questions that people have sort of thrown at us throughout. A couple. I'm going to start with a couple from myself here, and I apologize, by the way. That little blue doodle there, we think someone just managed to scribble on the whiteboard by accident, but nobody knows how to actually delete it or make it go away.
Oh, okay. I was thinking it was a PowerPoint thing.
Yeah, I'm not sure, but we're all looking at it going, I don't know. So a couple of questions, starting with a couple from myself. You talked a lot about minimizing hypoxemia and maximizing perfusion and oxygenation in trauma. I know that with our current understanding of specifically MI and cardiac events, the wisdom used to be a decade ago that we were trying to hyperoxygenate these patients, just flood them with as much oxygen as possible. And we've moved away from that over the past 5 years. I think it was one of the last ILCOR updates in 2015 or so this happened, where we actually realized that hyperoxygenating started to reduce cardiac output a little bit. And so we started titrating oxygen administration in MI as well. Is there any indication that we might be going that way in trauma? And if not, why not? Because if we're seeing a decrease in cardiac output from hyperoxygenation in MI, help me out here in understanding why we wouldn't be seeing the same decrease in cardiac output in trauma, and why that wouldn't be a bad thing.
I mean, that in itself is a very detailed question. We have X's going the blue line. It's a very detailed question, and the net result is I don't have a definitive answer for you. In other disease states such as MI or CVA, there's been a pull away from hyperoxygenation, and that's normally due or described as the risk of the release of free radicals causing further tissue damage and other cellular challenges, or in the case of MI, resulting in a reduced myocardial output. My opinion would be that in your trauma patients, because you're already dealing with an altered disease state in the sense of low oxygen carrying capacity secondary to anemia, increasing your overall PaO2 as high as possible is going to improve your tissue delivery. If there's a concern, though, certainly you can look to the patient's presentation. Again, ideally mentation or skin signs in order to guide that. And then in conjunction with your SpO2 monitor, targeting for 95 to 99% ensures that you're not in that hyperoxic state. Currently, the literature is supporting the routine application of oxygen. Again, and it's in that interest of providing oxygen to an already depleted system to provide perfusion to that tissue.
Good answer. Thank you. Another question I'm just going to blitz through my own questions first, and then there's a few from some other folks. And also, Jeff, I don't know if you can see the chat or not. There's like half a dozen people all saying thank you for your incredibly informative lesson from sort of all over the country. So you hit a good chord with everyone.
Thank you to everyone for asking me to come and talk. It's a pleasure.
With hemostatic agents, I don't have any personal experience with hemostatic agents because they're not within our scope at the BLS level with BC Ambulance or with BCHS, which is where I work. I understand there can be a component of significant exothermic reaction when they're applied with actual thermal burning. Can you talk a little bit about that? And just like this is something that's just right outside of my area of knowledge and expertise, and I'd love to just know a little bit about what's going on there.
Of course. So the concern with significant exothermic reaction certainly was a concern with the first generation Quick Clot product. Now, Quick Clot as a corporation has changed their active ingredient. So before they used a product, I believe it was called Zeolite or something to that effect. And as a action, when it came into contact with blood, significant amounts of heat were created. And that did two things. One, it aided in quasi-cauterizing the wound, but it also kick-started the coagulation cascade. The challenge with it is that it also charred the wound track, making debridement challenging. So it was not a fan of surgeons. And then the other component is significant pain and secondary injury, up to and including second-degree burns. Now, QuickClot has changed changed their active agent. They're now using kaolate, I believe is how you pronounce it. And again, it is under that procoagulant category of hemostatic agents. And its sole, or being an aluminum silicate, it's able to speed the reaction without the exothermic reaction, but also acts directly on factor 12, indicating the intrinsic pathway of coagulation. So you still need to have clotting factors present. And if you're in a significant coagulopathic state or dilutional coagulopathy, your hemostatics are less likely to work. But they're still first gen, so they're widely used in the military. Again, my personal experience has been with the Pitocin through products like Celox, and between the two of them, it's my preference. A, they're easier to clean out of the wound track for definitive care, but the other more important thing is they don't actually require clotting factors to work. They work independently upon contact with that blood product.
Good, thank you. That was fantastic. That's more than I was asking, but it was fantastic. A couple of quick comments from folks. I have a couple more questions myself, but I don't want to skip over everyone else's questions as well. Brian, in his naval closet there, notes that trauma equals naked eventually, and you know, I think a lot of what you're talking about today, Jeff, was a good reminder of that as well. I certainly have had experiences where, you know, you think you're dealing with most of your traumatic injuries, and then just before you get to the hospital, you end up getting the remainder of the trouser leg off or something like that, and realize that you've actually missed something. It's like, oh well, now I just look an idiot, right? But it's a good.
And just to further expand on that, I mean, the trauma equals naked, or the old strip 'em and flip 'em techniques are still vital in a complete and full trauma assessment today. But we need to be selective when we do it. Again, paying attention to the risks of compounding hypothermia and its effects on the triad. We need to make sure that we're doing it in an intelligent manner, and perhaps saving it for after the patient is in the back of the warm ambulance or in a clinic, and you're ready to go and manage that concern effectively and hands-on.
Absolutely. A note from Austin, who just observed. Austin's a nursing student with us. He just observed that with neonates, they actually warm their stethoscopes in the hospital beforehand to prevent hypothermia from thermal transfer from the neonate to the stethoscope, because the actually is such a significant heat sink.
Yeah, no, your neonate population, their thermal controls are not fully developed, and their body surface area relative to their internal mass is vastly disproportionate. So even small things like warming the stethoscope before assessment make a huge difference. The other component is blood loss in itself. For the average person, you've got 6 to 8 liters of blood running around. So you can afford to lose a significant amount of volume to the ground. But in your pediatric or neonate population, your total circulating volume is literally a can of Coca-Cola or less. So even small hemorrhages can be catastrophic in that population, and it makes aggressive management all that much more important.
Yeah, it's very much the same with thermal burns to the skin as well in neonates and kids and smaller people in general. Another question. Oh, and Austin actually wants to just corrected me. He has in fact graduated, so he is an actual registered nurse now. So congratulations on finishing that, Austin. That's been a long journey.
Congratulations, sir.
Another question from Austin regarding mean arterial pressure. He thought 60 or 65 was for cerebral perfusion, not renal perfusion. Are you able to clarify that at all?
Certainly. So it depends on what target you're looking at. The original studies were looking at end organ perfusion, and the two places they were looking at were both brain perfusion as well as renal perfusion. And 65 was kind of chosen as a happy medium to provide appropriate perfusion to both. Now the challenge with cerebral perfusion is that it also comes down to cerebral or intracranial pressures. And in order for the average individual who's standing up and walking around, your pressures are sitting at around 2 to 5. And for the average person who's laying down, your pressures are sitting around 8 to 12. So for the average individual or average adult, you can manage your blood pressures versus your cerebral perfusion and versus your intracranial pressures fairly easily with a mean arterial pressure of 65. Now, in your hemorrhage patients, in your TBI patients, all of a sudden now your intracranial pressure starts to increase. And once that happens, we need to go and start to match with mean arterial pressure. So our minimum goals for a TBI patient are a mean arterial pressure of 80. And that's due to the theoretical change or intracranial pressure of 20. So 20 minus 80 minus 20 equals 60. So it means that our goal, all of a sudden now we're pushing for a higher mean arterial pressure in order to overcome that intracranial pressure and still maintain cerebral perfusion.
That's a great answer. Thank you. I'm just copying one more question that someone came up with here.
I've got one here from Susan. MFR is not allowed to pack severe bleeds. Do we use tourniquets instead? Absolutely. Use whatever means that you possibly have to control hemorrhage and control it aggressively. The net result is we're trying to slow or stop the bleed to prevent worsening volume loss. There may be a change within MFR to allow packing in future, but that's not a discussion that I'm qualified to answer.
Yeah, tourniquets are a bit of a weird one for us because they've been embedded in standard first aid practice for a very, very long time, which is technically a prerequisite for the MFR, but I don't think we actually touch on them in the MFR itself. So you've been taught it at some point, but we don't actually reteach it. I can't, with a severe bleed, I can't really imagine a circumstance in which you've got a severely bleeding patient and you're sitting there with a triangular bandage or a commercial tourniquet in your hand saying, oh, well, I don't know. Certainly I think most of us have been trained somewhere along the way to use tourniquets. And there's certainly, we've certainly had our divisional medical officer and even our provincial medical officer, endorse their use. So even though they're not explicitly covered, they're sort of a reasonable thing there.
The only other big one with regards to tourniquets is, I mean, they're a fantastic tool because they're easily fashioned out of nothing.
Yes.
Really, for a tourniquet, all that you're looking for is something with an average width of 3 to 5 centimeters or 2 to 3 inches in width in order to apply appropriate constriction. People have tried to use belts before. The bigger challenge with using a belt is not often you're able to get enough compression through manual pulling of the belt tie, and instead looking towards using a triangular or a piece of cloth and then fashioning a windlass out of a long straight object. Funnily enough, chopsticks tend to work the best for improvised, or pencils tend to work fairly well for improvised windlass. And the worst out of the bunch are tongue depressors. They like to break whenever you put any kind of strain on them.
I have a couple thoughts on that, Jeff. One is that we universally, St. John, we actually invented the triangular bandage way back when, like 150 years ago. But it's still an absolute fixture in all of our first aid kits. And a lot of us are actually, you'll probably remember these, Jeff, the old oxygen tanks that you actually had to have an oxygen tank wrench to crack the valve on. So those are actually certainly on Vancouver Island, at least. I don't know for St. John elsewhere, but those are certainly standard for us, and those actually do make good improvised windlasses as well, for what it's worth. I've never had to use one in the field, but I certainly have used them to improvise in the classroom before. We had a question from Nicole about what about patients who have a naturally low blood pressure? And this was during the talk about permissive hypotension and MAPS and all that. So, you know, as an example, I'll pick, we have one of our St. John members in Victoria who's tuned in right now, who I won't mention by name, who's like 5'4" and 120 pounds or something. And then you have me who's 6'4" and 400 pounds. Clearly, you know, we have different baseline blood pressures. Do you give that any consideration?
So again, well, first off, the comparison of somebody small versus somebody large isn't necessarily a fair comparison. The net result is your cardiovascular fitness and whether or not you have any catecholamines that are causing vascular squeeze, and that's going to have a direct impact on your blood pressure. Remembering that systolic, your big number, is relating to the force of blood ejected, and the squeeze of the heart, and your little number is relating to how tight the pipes are, your afterlug. So, but in patients who have a normally low blood pressure, the biggest thing that we can go back to is looking at secondary signs for tissue perfusion. For an individual who normally walks around with a systolic or a blood pressure of 98 on 60 and feels fine and is doing all right, there's nothing medically wrong with them. So really what we're looking at is we're looking at their mentation, we're looking at how they're operating. Is there any confusion? What's their overall picture? And that is the goal within the permissive hypotensive tension, is to move away from a fixed number. You can use it as a goal point, you can use it as a target, or you can use it as a trending tool to say, you know what, if we drop below a systolic of 70, then we're going to consider fluid challenge, unless there's no signs of hypoperfusion. So really focusing on the CNS as your early warning marker or your canary, in my opinion, is your best course of action.
Great answer, thank you. Still like probably about 4 or 5 more questions to dig through here. The X-Stat wound packing injector, that was the pellet injector, and the pellets then, you know, expand like the dinosaur sponge in the cup, same idea. There was a question about, are those an issue for surgical removal? You know, I mean, clearly someone who's receiving one of these is going to be going to a trauma surgeon for surgical intervention at some point. Presumably radiopaque?
So they are radiopaque, but the other component is that they're a surgical sponge. So it's no different than what they're using in theater for mopping up bleeds. The only difference is that they've hyper-compressed it into this tube, and then once injected, it goes. So really the only challenge with cleanup afterwards is the removal, which appropriate irrigation should loosen the clots around the wound tract itself and allow for easy extraction.
Right. With tranexamic acid, if I recall correctly, and I'm going a bit from memory here, but if I recall correctly, administering your TXA too fast can cause a hypotensive dip. What's the physiology behind that? What's actually like, is it actually just mucking? Well, what is the physiology behind that?
So tranexamic acid in the body has a number of different effects and working on many different receptor sites. As far as answering the question, I can't with a high degree of certainty, so I'm not going to try. But I too am aware that it is a concern with rapid administration. So slowing your administration down over 1 to 10 minutes is reasonable. However, I have pushed it personally and I've seen no ill effects. So based on my observations, it's likely a occurrence that occurred in a small subset of patients. and is not a significant issue, but it's one that is worth noting. And safe practice would be to administer it slowly.
Great answer, thank you. If I recall correctly, this might have changed. Our treatment guideline at BCHS used to be over 10 minutes. I feel like that might have even been accelerated down to 5 or something like that, but 10 is probably not an unreasonable goal. For those of you that are licensed and doing it or administering it and all that appropriately within your scope and everything, might not, the exact, whether it's going to be 9, 10, or 11 minutes is probably not the thing you should be busting out the calculator for if you're giving TXA to someone.
And the further follow-up is that your initial dosing of TXA is a bolus dose, we're giving 1 gram over 10 minutes. But then if you have a prolonged transport time, you can also opt for going and starting the maintenance dose, which is 1 gram of TXA over 60 minutes. And that is to go and continue the potentiation of the effects of TXA through for the surgical day.
Good to know. We, I believe for the BLS cars around here, we only actually carry 1 gram on car. But, certainly in other areas, or if you're departing a hospital or something, it's good to keep in mind. Chris Turner had a question about the Cellex hemostatic agent and people with shellfish allergies. If you know your patient has a shellfish allergy, definitively this person has a shellfish allergy, would that make it contraindicated or not?
So that really comes down to your agency who's writing the protocol and what the medical director is willing to sign off on. When I was with Alberta Health Services, we did have the CELOX impregnated gauze, and a known shellfish allergy was a contraindication. But under the manufacturer and the FDA, they have approved it for people even with a shellfish allergy, and that's secondary to the heavy amount of processing that shellfish shell goes through prior to being packaged. So the risk of affecting a IgE-mediated response is extremely low.
Great answer, thank you. There was a question from Lisa Ann about what over-the-counter products are available to volunteer brigade members for scope practice for hemorrhage control. The short version is nothing. I have one person who's chiming in that we do in fact have 2 grams of TXA. We have 1 in the BLS jump kit and 1 in the car. So we do have 2 grams of TXA locally here. There you go. I do remember that now. I just hadn't been thinking about it. To finish answering Lisanne's question there's nothing in terms of over-the-counter commercially available hemostatic agents that are available and within scope for MFRs, unfortunately. There's a question from Austin regarding angulated fractures. On the picture of the fractured wrist hand with an angulated fracture, how would we stabilize something like that that's not straightened? We have these great devices on car, and St. John, at least in Victoria, has these as well. They're called SAM splints, and they're actually a flexible, moldable splint that you can literally bend into any shape that you need to bend it into. And then once it's bent into that shape, you can camber it in a certain way to maintain rigidity in that position, and you can just splint stuff in position found. There are some hypotheticals about like you're in a remote location, help is many hours away and all this, and we start talking about repositioning and stuff. I think that's well outside of the scope of what we're likely to be dealing with as St. John members. So the short version is splinted in position found and call for a higher level of care. Couple last questions. There were some questions from someone named ROC Planning asking about options for internal hemorrhage control, and specifically thoracic and abdominal hemorrhage that is not packable.
That was a slide that almost made it onto the presentation that got left off. For the pre-hospital side of things, TXA is still the go-to. Reduce movement, position the patient appropriately, focus on perfusion and managing the trauma triad, and get them to a surgical site. But the other component is what happens or in hospital if you have a significant extremity hemorrhage, especially in the lower portions from kind of mid-chest down after the aortic arch. They can go and do a procedure called a ROBOA. So they end up floating a flexible balloon up into the descending aorta. They inflate it and essentially shut off all blood flow to the lower portion of the body. Now, that is a intervention that is being done in field in areas that are serviced by physician fly cars, such as France and London, but is not presently practiced within the pre-hospital realm in Canada. There is a commercial product out there which it looks a little bit like a reverse fanny pack and is a pneumatic wedge device, which is marketed as a junctional hemorrhage control, essentially a positionable tourniquet that can apply pressure to the inguinal or the axillar folds, but further to it can be positioned over the abdomen, and when inflated can provide enough external compression to occlude the lower third of the aorta off and shut off blood flow to the lower extremities. So beneficial in your significant pelvic injuries or high amputation injuries that would otherwise be uncontrolled.
Fantastic, thank you. I think the question was targeted specifically at if there was anything we could do at sort of like the PCP or MFR level or EMR level, and
comes down to the good old-fashioned diesel bolus.
Yeah, go fast, basically. I think that's it for questions. Oh, we had someone, Lisa, and what about if level 3 first aid trained? I'm not sure what your questions in specific relation to, Lisanne. Certainly if you're, St. John's been very clear that if you're out on duty for St. John Ambulance, you're restricted to an MFR scope of practice. If you're practicing outside of St. John and you have an active and current OFA level 3 first aid certificate, and there's a little bit of difference here between the OFA 3 that I took many years ago and what it is now. But if you've got other treatment options that you've been trained to do within that, and you're not on a St. John duty, you would be quite reasonable to use those as well. Certainly out for St. John, the company line is we're restricted to what's covered in the MFR scope. Are there any more questions?
At the end of the day, it comes down to for any significant or uncontrolled hemorrhage, do what you have to control it. When working on your employer under a particular umbrella, you need to follow their requirements and protocols. But if we don't correct the bleeding, they're going to hemorrhage until exsanguination. And quite honestly, relying on the 5th rule of surgery, where the bleeding will stop eventually, is not an appropriate means of hemorrhage control.
Yeah, no, I fully agree with you there, Jeff. Lisanne just clarified, she said regarding assisting on your personal time or responding as a good Samaritan, I would say if you're responding as a good Samaritan, you should probably practice at the highest level that you've been trained and certified as, would be my thought. Do we have any more questions from the gang? This has been a very...
as far as the template, yes, it was a free template found online and then heavily modified.
Oh, Kamloops is saying thanks. Keen O'Brien. I think unless there's any more questions, everyone's had quite a while to check their questions. I think if there's no more questions, I think we're going to pass on our thanks to you, Jeff, very much. That was a fantastic presentation. It really was. It's really great to get to do a deep dive into some of the physiology behind some of this stuff. As someone else observed in the chat earlier during the presentation, we very often focus a lot on what our treatment modalities are, and don't always don't always get into the how and why of how all this stuff happens and why it happens and stuff. So thank you very much for that. And I see lots of things coming in from a whole bunch of folks. If there's no more questions, and Jeff, I don't know if you have anything else to throw at us for the evening. If there's no more questions, folks, I think we'll call it an evening. Next week, we had a little bit of a last minute schedule shuffle. We're still trying to book someone definitively. There's a reasonable chance that next week will be myself talking about hyperbaric medicine and dive medicine. That's sort of our ace in the hole, but we are trying to find a different guest speaker. Just a reminder, if anyone in the group is is a qualified healthcare professional, we're thinking paramedics, nurses, doctors, who has an interest in presenting, do feel free to drop us a note. Any COVID-19 extra precaution? One more question here. Any COVID-19 extra precautions? I'm not quite sure what context that question's being asked in, but I think following our public health officer's advice is probably, broadly speaking, for public stuff. Certainly for, in a healthcare setting, we're all wearing respirators, face shields, full gowns for anyone that's symptomatic, all that sort of stuff. Yeah, I'm not sure if that question was targeted any more specifically. In regards to approaching during personal time, I'm reading Civic 19 as COVID-19. I think you're being auto-corrected there. As with anything, if you've got a patient or someone, who you are potentially looking at as a patient who needs your help, the usual rules about protecting yourself and maintaining your own safety first still apply. So if you don't have the appropriate PPE, so either an N95 that you've been fit tested for, or a half mask respirator and a face shield and gloves and a fluid impervious gown, you probably shouldn't be treating that patient. You should probably call 911 and let the folks who do have that equipment show up to provide that person some care, which is a really difficult thing to do. I recognize that's a difficult thing to do. Sure, praying for healing might not be a terrible plan while you're waiting, I guess. For next week, folks, maybe me talking about hyperbaric medicine, maybe someone else if we can squeeze someone else in. The week after that, I believe we have a talk, or we're supposed to have a talk, still being finalized, from our critical incident stress team, talking about self-care and psychological self-care, particularly during COVID, but also during our day-to-day practice. Look forward to seeing everyone next Monday. Thank you very much. And who's giving that talk? The CISM one is from the St. John CIS team. I don't know the name of the person because I'm not the person coordinating that talk, but it is from our internal CIS group. Thanks very much, folks. We look forward to seeing everyone next week, and take care. Oh, Nahum says we're trying to get BCEHS to speak on CIS. Nahum, drop me an email at my work account if you want, and I can put you in touch with Anna, who's coordinating these talks. Every time I try and say goodnight, people are throwing more at me. Okay, folks, you know where to reach us if you need us. We look forward to seeing everyone next Monday. Lisanne, you're saying, can we get a copy of the talk? As with all of our presentations, these are getting posted onto YouTube. This will go up hopefully in the next 24 hours onto the St. John Ambulance Victoria YouTube channel. Just go to YouTube and search SJA Vic BC. If you're on our email list, you will get the email links for those talks. If you'd like to reach out to us and follow us on social media, you should see the social media tag at the bottom of the slide that's on the screen right now. Do give us a look-see on YouTube. Again, just go to YouTube and search SJAVicBC, SJAVICBC, and you'll find our channel with all of our archive talks as well. Thanks very much, folks. Have a great night. Thank you again, Jeff, and we'll see everyone next week. Take care, guys. Good night.